Hi everyone, I'm Christina, still one of the interns. I'm going to be presenting on acute transfusion reactions. So we are going to talk about acute transfusion reaction, how to recognize an acute transfusion reaction, initial management of acute transfusion reactions, and then go over TACO versus Trolley. So case presentation is a 46-year-old female. She has history of diabetes, hypertension, heart failure with reduced ejection fraction. She's coming in today because she's feeling lightheaded, very weak in the setting of 4 weeks of vaginal bleeding. She says the bleeding was very heavy when it initially started. She was using about 1 pad every 2 hours. Since then, it's gotten much better, but she feels like she's going to pass out. So she came in today. You look at her triage vitals and they are totally normal. She's not hypotensive, she's not tachycardic, but she looks very pale. She has pale conjunctiva. Her heart, lung, and abdominal exams are normal. On gyne exam, you notice some moderate amount of blood in the vaginal vault, and you also see +1 pitting edema of bilateral lower extremities. And her EKG is regular, normal sinus rhythm. This is her first time here, so you don't have any basic labs, and some of them start to come back. You're suspecting anemia, so you sent type-in screens, coags, CBC, CMP, and her CBC comes back. You see a hemoglobin of 5.1. In addition to that, she has elevated creatinine, BUN. Unclear whether this is something acute or maybe it's because of her chronic medical problems. Her chest x-ray shows clear lungs, but you notice that her heart is a little enlarged. So at this point, she has some active vaginal bleeding. So you consult GYN, she consents to a transfusion, and you start the first unit of blood in the ED. About an hour later, the nurse calls you over and says the patient's having difficulty breathing. So what do you guys think is going on at this point? Yeah. So patient is likely having an acute transfusion reaction. So you want to assess your patient, and in this case, the patient was now tachypnic, tachycardic, hypertensive, as opposed to being normotensive when she came in. She's hypoxic to 49% on room air. You hear bilateral rales, and you notice some new JVD. So this patient is having an acute transfusion reaction. You should suspect an acute transfusion reaction in anyone who develops adverse signs or symptoms within the first 24 hours, during or within the first 24 hours of a completion of a transfusion. Most common symptoms are pruritus, urticaria. In these cases, you can give some antihistamines to make the patient feel more comfortable. Another common symptom is fever. This one is kind of important because fever can be benign in the case of febrile non-hemolytic transfusion reaction, but this is a diagnosis of exclusion because fever can also present as one of the life-threatening reactions, such as acute hemolytic transfusion reaction, transfusion-associated sepsis, and Trolley. So if a patient develops a fever, you want to stop the transfusion, wait at least 30 minutes. If it resolves, then it may be safe to continue. If it doesn't resolve, then you have to investigate for one of those 3 life-threatening transfusion reactions. If a patient develops adverse signs or symptoms while receiving a transfusion, you want to stop the transfusion. Have somebody take a look at the bag, make sure that it's for the correct patient, call the blood bank and let them know that they're experiencing a reaction. And then at the same time, you want to assess your patient. So start from the top, ABCs. You want to make sure they have a patent line just in case you have to give any medications, diuretics, fluids. So for ABCs, you want to take a look at their airway. Some of the, anaphylaxis can present with swelling of the airway, in which case you can give epinephrine right away. You want to take a look at their lungs, take a listen to their lungs. If you hear some wheezing, again, that could indicate anaphylaxis, whereas if you hear rales, it could be TACO or Trolley. And then circulation, you want to take a look at IV lines and access points. If you notice some oozing from IV lines, that could indicate DIC, and that can actually be the only sign that an intubated patient is experiencing a transfusion reaction. Then you want to check the patient's vitals, as vitals can help indicate which one is going on. And do some imaging. So bedside, you can put a probe on and check for B lines, get a chest x-ray to check for new infiltrates. So now I'm just going to talk about TACO and Trolley. These can present very similarly. They can actually present together, so it's sometimes hard to distinguish the two. So they usually present with respiratory distress, crackles, rails in the lung fields, sometimes hypoxemia for Trolley, hypoxemia, TACO sometimes, and then chest x-ray, new chest x-ray findings. There are ways to differentiate the two as well, and it's important for definitive management. So first I'm going to speak about TACO. TACO is one of the most common acute transfusion reactions, and it's important to identify it because it has a very high mortality rate of about 32%. It's a form of cardiogenic pulmonary edema and circulatory overload. So patients that get this, some risk factors are patients who have CHF, chronic kidney disease, very old patients or very young patients who are volume non-compliant. And also it's correlated to the amount of blood given. So the more you give and the faster you give it, the more likely you are to develop TACO. The way that you can help distinguish TACO, particularly, you can send some blood work. BNP will be elevated in these patients because it's a form of cardiogenic pulmonary edema. Troponin can sometimes be elevated if there is demand ischemia. Chest x-ray will show cardiopulmonary edema, and then on echo, you'll see a reduced ejection fraction. And then to treat these patients, you want to sit them up so that they're not orthopnic and not drowning in their own fluid, and diuresis. Start IV diuresis. You can treat this as like a CHF exacerbation. You can give nitrates, you can put them on BiPAP, and you can even do phlebotomy, so kind of take out the blood that you gave. And then to diminish the risk of developing TACO in patients who have risk factors, such as dialysis patients and CHF patients, you can transfuse and diurese or dialyze at the same time, and also give the transfusion at a slower rate. And then Trolley is also presents with respiratory distress, but it differs because it can also present with fever, pink frothy sputum, and unlike TACO, it requires hypoxemia and new chest x-ray findings. This one also has a high mortality rate of 30%. Some risk factors for developing Trolley are being super sick to begin with, being an ICU patient, females, transplant patients, smokers, ETOH users. And the mechanism by which Trolley happens is thought to be like a two-hit hypothesis. So first one being that your neutrophils are out and primed. And then the second one, the donor blood has anti-leukocyte antibodies, which then bind to your neutrophils and cause cytokine release and pro-inflammation. And then there's capillary leakage causing these aggregates to leak from the capillaries into the alveoli. And on labs, actually, some patients have a transient neutropenia because their neutrophils are being used for this purpose. And there have been things implemented to try and reduce the risk of Trolley, such as leukoreduction, red blood cell washing, filtering. But actually, even when this is done, patients still develop Trolley. So there's no good way. Oh, but right now, I think in America, it requires that plasma donors be only males, because females, when they get pregnant, they develop antibodies, and then the more pregnancies, you develop more antibodies. So that plasma carries more antibodies to begin with. So this is just the mechanism of how the pulmonary edema differs in both. So on the left, we have a depiction of TACO. Here you have an increase in hydrostatic pressure that's pushing the fluid from the capillaries into the alveoli and actually causes a transudative effusion if you were to check. And then on the right, we have Trolley, which causes increased permeability of the capillaries and leads to an exudative effusion. We don't check what kind it is, but if you were. And then here is just a quick summary of the differences between the two. So in Trolley, you are likely to see hypotension as opposed to hypertension in TACO. Fever is common with Trolley. Chest x-ray, it's going to look like ARDS in Trolley as opposed to cardiopulmonary edema and vascular congestion in TACO. BNP is going to be elevated in TACO. Ejection fraction will likely be reduced. And in TACO, if you give diuretics, patients are going to improve, whereas in Trolley, there's not a consistent response. But if you're having trouble distinguishing between the two, you can do a trial of diuresis. So you can give a diuretic. If the patient improves, then it's likely TACO. If the patient does not improve or worsens, then it's most likely Trolley. So our patient, blood work showed elevated pro-BNP of 14,000, slightly bumped troponin, reduced ejection fraction compared to her previous of 35 to 40%, and then this was her x-ray. Patient was admitted to the ICU, started on diuretics, and her condition improved. And this is just a quick slide that compares relative risks of developing these reactions from one transfusion compared to like other super rare things, such as you are almost as likely to develop fatal hemolysis as you are to die in an airplane crash or be killed by lightning. TACO and fever are very common, and then Trolley is more rare than TACO. Yeah, so in summary, acute transfusion reaction occurs within the first 24 hours after receiving a transfusion. You want to stop the transfusion if a patient develops a reaction, do your ABCs, chest x-ray labs, do a complete physical exam. You want to try to identify the type of transfusion reaction by your exam and vitals and manage it accordingly. And you can differentiate between TACO and Trolley using blood pressure, chest x-ray, your physical exam findings, BNP, and a trial of diuretics. Yes.
That's very good, Christina. I've seen both of these, not a lot, they're not very common. I've seen a few times. And one thing I've been impressed with is, and you mentioned it, but BiPAP can help both. Mm-hmm. And especially important to oxygenate them. And this woman, in retrospect, was kind of a setup for TACO, because you see that big, big heart. So again, as you said, you can give the transfusion slower. You know, instead of usual 2 to 3 hours, you can give it 4 hours or even up to 6. If you wait too long, then you increase your chances of sepsis, you know, infecting blood. So you have to measure out. You can't give it too slow. But you can also, like you said, as long as their pressures are okay, you can give them diuretics prophylactically at the same time that you're giving the transfusion. You can give them Lasix or something, provided you're already thinking they may become fluid overload. You have to be careful. Again, it's really evaluating them and reevaluating them. Mm-hmm.
I like the takeaway you bring the bioscience.
Thank you.
Yeah, and this is the reason why, right, this is like an OBS like potential diagnosis, right? It's because when you give transfusions, there is a 1 in 100 chance that you see on the table there of developing TACO. This is why patients, they really do need to be watched kind of carefully. And if you don't feel like you can do that in the ED, right, that's why we try to put the patient at least on OBS so that they can be watched closely. And you guys are the residents on OBS, this is really the main thing that you're trying to manage with these patients, not just trying to get the blood. And once the blood's home, that you're kind of done with the patient, they're good to go afterwards. You really want to be just checking on them throughout it to make sure if you get any early symptoms of any of this, you can stop the transfusion and prevent any complications.